موجود السلايد الكل موجود الكل ده يسمعني؟
ايه دكتور
موجود
موجود.
دكتور موجود.
تمام. Good evening. Thyroid and parathyroid. Now last session we have studied the larynx. Today we will study the endocrine part of the neck. And the endocrine part of the neck is composed of two glands, thyroid and parathyroid glands. We will start with the thyroid gland. Now, the thyroid gland is the largest endocrine gland in the body. It's a single gland, but it's formed of two lobes, right and left, with an intermediate part joining the two lobes. We call it the isthmus of the thyroid. In this slide, you are seeing this slide, which contains two pictures. Now, on the left below, this shows the two thyroid lobes with the middle portion which joins the two lobes, which we call it the isthmus of the thyroid gland. So it's formed of left lobe, right lobe, and isthmus of thyroid gland. It's an endocrine gland. So it's a ductless gland, has no ducts, and this gland secretes thyroid hormones T3 and T4, thyroid hormone 3 and thyroid hormone 4. The thyroid gland, each lobe of it, this is applied to the lateral aspects of the larynx and the trachea. And the trachea it descends till the sixth trachea ring that is in level with the lower border of 6 cervical vertebrae. Each lobe of it extends from below the oblique line of the thyroid cartilage and is applied to the thyroid cartilage to descend down to the level of the 6th trachea ring. That is the lower border of 6 cervical vertebrae. The isthmus of it, this lies over the trachea rings, 2nd, 3rd, and 4th trachea rings, joining the two lobes of the thyroid gland. So each lobe extends superiorly from the oblique line, superior end of the oblique line of the thyroid cartilage. If you remember, this is the oblique line of thyroid cartilage, which gives rise to muscles and to the infrahyoid muscles, and then descend downward till the level of 6 trachea rings, joined to its fellow by the isthmus of the thyroid cartilage, which is applied to the second, third, and 4th tracheal rings. The thyroid gland is enclosed by the pretracheal fascia together with the larynx, and so it moves with the larynx during swallowing. So when you want to examine for the thyroid gland, if there is any enlargement or anything abnormal, and it just asks the patient to swallow, swallow, and then this moves with it, with the larynx, because the larynx move upward, and then it takes with it the pretracheal fascia because it's enclosed by the same fascia with the larynx. Now, the relations of the thyroid lobes. Each lobe, it has a posteromedial surface or posterolateral surface, medial, lateral, and the anterior surfaces, medial, posterior, and anterior surface. Here is the anterior surface of the thyroid, the anterior surface of the thyroid lobe. Each is covered with pretracheal fascia, and then is covered by the infrahyoid muscles, is covered by the two layers of the infrahyoid muscles, the sternohyoid muscle and the thyrohyoid muscle. Here is the sternothyroid muscle from the sternum to the thyroid, and then we have the thyrohyoid muscle here above, and then we have the sternohyoid deep to it. This is the cuttage of one of the sternothyroid, and deep to it, this muscle is the sternohyoid, and then the sternothyroid muscles. These are the strap muscles related to, and then it's covered, of course, with the investing layer of deep cervical fascia, and then the superficial fascia and the skin. So when you want to open and operate over the thyroid gland, you should open over the skin, the superficial fascia containing the platysma, and then you come to the investing layer of deep cervical fascia, then to the two layers of strap muscles, sternohyoid and sternothyroid, and then you come to the pretracheal fascia, which encloses the thyroid gland. So these are the superficial relations or anterior relations of the thyroid lobe. Posteromedially, or the medial surface of it, is related to the thyroid cartilage, to the cricoid cartilage of the larynx, and posteriorly, posteromedially is related to the pharynx above and then to the esophagus below. So two tubes, superiorly is the larynx and pharynx, and below becomes the trachea over the tracheal rings, and lateral to it, posteriorly, posteromedial is the esophagus, So two tubes above, which are the larynx and the pharynx, and then below the trachea and the esophagus. Below the larynx continues as the trachea, and the pharynx posterior to it continues as the esophagus. So the posterior surface of the thyroid is related to these two tubes. Between these tubes enters two nerves. It enters the superior laryngeal nerve, the internal laryngeal, enters deep to the thyroid lobe, the internal laryngeal nerve, descend downward, and from below the superior, the recurrent laryngeal nerve enters from below here. We have seen below the inferior constrictor and becomes deep to the thyroid gland. And two muscles also lies deep to it. The inferior constrictor, which arises from the oblique line of thyroid cartilage deeply, and the cricothyroid, and this cricothyroid muscle, cricothyroid and the inferior constrictor. So there are two muscles, two nerves, two tubes, two superior tubes, larynx and pharynx. Below is the trachea and the esophagus. Two nerves, the internal laryngeal nerve, recurrent laryngeal nerve, from below, two muscles, cricothyroid and the inferior constrictor of the pharynx, separating these tubes from the thyroid lobe. So these are the relations of the thyroid lobe. The apex of each lobe is directed upward, and the base of it is directed downward. As I said, the two lobes are connected to each other by a single medium part, which we call it the isthmus of the thyroid gland. The isthmus posteriorly is related to the second, third, and fourth tracheal rings. Anteriorly are the same relations, just like the thyroid gland. Skin, superficial fascia, investing layer of deep cervical fascia, and then the pretracheal fascia with the strap muscles or the infrahyoid muscles. The thyroid gland, as I said, this is the largest endocrine gland, is single, produces thyroid hormone and calcitonin hormone. This is produced by special type of cells in the thyroid, which we call them C cells. It lies deep to infrahyoid muscles from level of C5 till T1 vertebra. It consists of two lobes, anterolateral to larynx and trachea, with an isthmus uniting them anterior to tracheal rings to second to fourth. Each lobe is limited above to the oblique line of thyroid cartilage down to the 6 or 7 tracheal rings. Surrounded by thin fibrous capsule, the gland is enclosed by pretracheal fascia together with the larynx and trachea, hence it moves with the larynx during swallowing. Relations, as I said, posteriorly, two tubes, larynx and trachea, esophagus and pharynx. Below, Then two nerves, external laryngeal and recurrent laryngeal nerves. Two muscles, cricothyroid and inferior constrictor muscle. Anteriorly, the skin platysma with the superficial fascia, and then investing layer of deep cervical fascia with the two layers of infrahyoid muscles, sternum hyoid and the sternothyroid, and pretracheal. Pretracheal fascia, the isthmus, the same anterior relations, but posteriorly as tracheal rings, second, third, and fourth tracheal rings. Now, sometimes the thyroid gland might contain a small portion like that above the isthmus, pyramidal in shape. This is called pyramidal lobe. It's not present in all people, and it's about 20 to 25% of people the pyramidal lobe is present. Now, this is the remnant of the development of thyroid gland. I don't know whether you have studied in your embryology. The thyroid gland develops from the floor of the oral cavity as an epithelial-derived tube. It descends downward into the anterior aspect of the neck and the larynx, and then divides into two portions. This we call thyroglossal duct. It divides into two portions. Then the thyroid gland develops within these two lobes and the thyroglossal ducts from the floor of the oral cavity. It becomes completely closed and disappears. Sometimes a portion remains above the thyroid lobes, above the isthmus as the pyramidal lobe. The thyroglossal origin of this thyroglossal duct, and in this shown in the adult. If you remember, in the tongue, we said there is the V-shaped sulcus, and in the center of this V-shaped sulcus, we have the foramen cecum, which is a closed foramen, is a depression between the anterior 2/3 and the posterior 1/3 of the tongue. This is the site of origin of the thyroid gland. The thyroglossal duct descend from there and then come through downward to reside over the larynx and the trachea. Sometimes portion of this thyroglossal duct remains as a glandular structure, become attached to the hyoid bone like a ligament extending from hyoid down to the isthmus. This is called levator glanduli thyroidi. Levator glanduli thyroidi, and is a remnant of thyroglossal duct. So pyramidal lobe, 50% of people extends superiorly from isthmus. Sometimes a fibrous band might connect it to the hyoid bone. This we call it levator glanduli thyroidi. Levator, it means it elevates glanduli, it elevates thyroid gland. Now the blood supply of the thyroid gland. The blood supply of the thyroid gland, being an endocrine gland, it has a profuse blood supply because it powers secretion directly into bloodstream. It's a ductless gland. It's not like the salivary gland, which you have studied with the oral cavity. This salivary gland had a duct which opened into oral cavity. This doesn't have duct. It's called endocrine or the thamma, and so it powers secretions into the bloodstream directly, and so it has a profuse blood supply. The blood supply of it is through two sources: a branch from the external carotid artery, which arises above the oblique, the superior border of the thyroid cartilage, and then emerge from external carotid. This is the first branch of external carotid, which is the superior thyroid artery. This is the superior thyroid artery. The superior thyroid artery descends toward the superior pole of the thyroid lobe and divides into two branches. One branch descends along the anterior border or medial border of the thyroid lobe toward the isthmus, and then anastomose with its fellow from the other side. And the posterior branch, which descends behind to posterior aspect of the lobe, and then this again anastomose behind with the other artery, which is the inferior thyroid artery. Now the inferior, the other artery which supplies the thyroid gland is the inferior thyroid artery. This arises from here, is not shown. It arises from the thyrocervical trunk of the subclavian artery. This is the subclavian and this is the common carotid. The subclavian artery here gives rise to thyrocervical trunk. And from this, the inferior thyroid artery passes deeply between the trachea and the esophagus, accompanying the recurrent laryngeal nerve, and enters behind the thyroid lobe and anastomoses with a divide again in a branch posteriorly, which anastomoses with posterior branch of the superior thyroid artery, and another branch which passes medially behind that toward the posterior aspect of the isthmus. Branches from these thyroid branches pass to supply the gland. Sometimes there is another artery supplies the thyroid gland, arises directly in the thorax from the aortic arch and ascends upward in the midline anterior to the trachea to pass toward the isthmus. This is called thyroidea Hema artery and is not present in all people. And when it lies anterior to the trachea, passing upward sometimes might be injured in doing tracheostomy. Thyroidea Hema artery. So two arteries mainly, superior thyroid, which divides into anterior and posterior, inferior thyroid from the thyrocervical trunk of the subclavian artery. Superior is branch of external carotid artery. They anastomose with each other and they give rise to the thyroid gland. In addition, we have sometimes thyroidea Hema artery, which passes upward from the arch of the aorta to supply the gland. Now, the venous drainage accompanies the arteries. We have superior thyroid vein, which passes upward to end in the internal jugular vein. We have middle thyroid vein, which passes to be again into the internal jugular vein. In addition, we have inferior thyroid vein, which arises from the anterior aspect of the isthmus and two inferior borders of the two lobes. The two unites with each other, and then this passes to end into the left brachiocephalic trunk. This is the venous drainage. Now, the nerve supply of the gland. The nerve supply of the gland has the gland, so it has sympathetic and parasympathetic. This usually leads to vasoconstriction and vasodilatation, but doesn't affect the secretion of the gland, doesn't affect the production of the thyroid hormone, because this is controlled by the pituitary glands in the cranial cavity. So the sympathetic is just for, and parasympathetic supply is for the vasoconstriction and vasodilatation.
دكتور
Yes.
عفوا عن المقاطعة.
نعم.
دا تشرح على صورة السلايد لو هل يعني
لسه كنت على صورة السلايد لسه داخله.
تمام، لأن أنا دا أشوف الملزمة يعني دا تشرح على يعني على
هسه بلاد سبلاي.
يعني هسه أنا طالع قدام الصورة.
هسه حولت أنا على البلاد سبلاي. على slide number 5.
هسه طلع. نعم دكتور.
تمام. So blood supply again, the gland is endocrine, so it's highly vascular because it has no ducts. It powers its secretion directly into the bloodstream. It's supplied by superior thyroid artery. Is the first branch of external carotid artery. It reaches superior pole of the lobe and divides into anterior branch, which descends along anterior border to anastomose with its fellow in the midline and posterior branch, which descends to posteromedial surface and anastomose with inferior thyroid artery. Inferior thyroid artery is a branch of thyrocervical trunk of subclavian artery. It runs superior-medially posterior to carotid sheath and to posterior surface of the lobe. The blood vessels, they pierce pretracheal fascia and lie on the capsule of the gland. Now, as I said, thyroid Hema artery. This is present only in 10%. The small unpaired, the single artery, usually arises from the brachiocephalic trunk or arch of the aorta, ascend on the anterior surface of trachea to isthmus of thyroid. As I said, it might be injured in tracheostomy, in doing opening in the trachea. Venous drainage, we have superior, middle, and inferior veins. They drain into superior middle thyroid, draining into the internal jugular vein. The inferior thyroid, as I said, drains into left brachiocephalic vein. Both of them, they unite with each other and they drain into left brachiocephalic vein. The lymph drainage of the thyroid gland from a capsular network of vessels over the capsule of the thyroid passes to prelaryngeal, pretracheal, and paratracheal nodes. Laterally, the lymphatics along superior thyroid artery pass to the lower deep cervical lymph nodes. Some may drain into brachiocephalic nodes or into thoracic duct. So they drain to the nearby glands, to the pretracheal, laryngeal, and paratracheal nodes. Laterally, then they pass to the along the superior thyroid to lower deep cervical lymph nodes. Some may drain directly along the vein into the brachiocephalic nodes or into the thoracic duct. Nerve supply. Postganglionic sympathetic nerves along arteries cause vasoconstriction and parasympathetic cause vasodilatation, while the secretion is hormonally controlled by the pituitary gland, by the thyroid stimulating hormone, which is secreted from the pituitary gland. Now, a few clinical notes about the thyroid gland. As I said, the thyroid gland develops as a protrusion from the epithelial lining of the oral cavity, and it leaves a pit on the surface of the tongue between the anterior 2/3 and the posterior 1/3 of the tongue, which we call it foramen cecum. The thyroglossal duct descends there and divides into two lobes, and then this duct disappears or remains as a levator glanduli thyroidi. Sometimes the duct remains opened congenitally, remains opened, and then materials, fluid might pass there and lead to accumulation of it in this duct and leading to cystic formation in the anterior medial line of the neck. This we call it thyroglossal cysts. Sometimes only portion of it remains as a cyst or complete open duct. These we call them median cysts of the neck because they lie in the anterior medial line, which is the line of the descent of the thyroid gland. Sometimes thyroid tissue might remain in the floor of the oral cavity that is in the foramen cecum of the tongue between the anterior 2/3 and the posterior 1/3 of the tongue. These we call them ectopic thyroid gland, and they might function and produce thyroid hormone. But usually these, since they are not in their normal position, we call them ectopic or aberrant thyroid tissue. These, they might undergo metaplasia and become malignant cells because they become subjected to trauma all the time when eating and might lead to metaplasia, and then usually they end with malignant changes. Ectopic thyroid gland, so usually is seen within the foramen cecum. Now the word goiter, which is in front of you, goiter, it means enlarging thyroid gland due to any cause. Once it becomes enlarged, we call it goiter. Sometimes one lobe is enlarged, the other it's normal, it's called lobular goiter. Sometimes there are portions inside it or cysts inside it. These we call them nodular goiter. So any enlargement due to any cause is called goiter. And to diagnose goiter, simple. just ask the patient to swallow. If this mass moves with swallowing, this means it's within the thyroid gland, so it's goiter. If it doesn't move, then this means it's outside the thyroid gland. So the word goiter is any enlargement of the thyroid gland, whether it includes the whole gland, which occurs in those cases who they have iodine deficiency and becomes hypothyroid, becomes enlarged. The whole thyroid becomes enlarged. Hypothyroidism due to iodine deficiency, which is common in some areas of Iraq. It's common in Kurdistan region, in the Hawk especially, and in the Diyala Governorate, where the water doesn't contain lot of iodine. So we add iodine to table salt or to food salt to prevent this hypothyroidism goiter. If it is tumor, if it is cyst, if it is any cause, if it is infection, inflammation, or due to iodine deficiency, any change in the size of the thyroid gland due to any cause, whether it is one lobe, the whole gland, or part of it, we call it goiter. Now, in some cases, we need to remove the thyroid gland, especially in thyrotoxicosis, where it is a toxic gland, when there are tumors. And removal of thyroid gland, we call it thyroidectomy. Thyroidectomy, it means removal of the thyroid gland. Now, whenever you remove an organ from the body, you should first, before removal, ligate the blood supply so that to prevent bleeding. So we ligate the superior thyroid artery near the upper pole. We ligate inferior thyroid artery near the lower pole. Sometimes when ligating the, I will go back to the picture. Is it now the picture with you? Is it the picture of the thyroid?
Yes,
A slide with picture. Now we should ligate. In doing thyroidectomy, before you remove the thyroid gland, then you should do ligation of this artery here, superior thyroid artery. Sometimes you might ligate with it the external laryngeal nerve here, and this leads to paralysis of cricothyroid muscle and loss of sensation in the larynx above the vocal cords. And you should also ligate the inferior thyroid artery, which is crossed again by recurrent laryngeal nerve. And sometimes with ligation of it, you might do injury to the recurrent laryngeal nerve, and this leads to paralysis of all intrinsic muscles of the larynx except the cricothyroid, and lead to paralysis of vocal cords. And if it is on both sides, it leads to suffocation, so you should do intubation. And once you remove the tube of intubation after the surgery, then the patient might go into suffocation. If it is on one side, the injury, then this leads to hoarseness of voice. One side of vocal cords will be injured, lead to hoarseness of voice. So thyroidectomy, you might lead to injury of recurrent laryngeal and injury to external laryngeal nerve. And whenever we do thyroidectomy, we should do it subtotal, not total or complete removal of the thyroid gland. We do subtotal to preserve other endocrine glands which are present within the thyroid gland. And these are the parathyroid glands. So by now we have finished with the thyroid gland. Now we pass to the other endocrine glands present in the neck, and these are the parathyroid glands. Now, is the slide of parathyroid with you?
Yes, Doctor.
Okay. Now the parathyroid glands are very small. We have two pairs of parathyroid glands. So we have 4 parathyroid glands, but we have only 1 thyroid gland. We have 4 parathyroids, but 1 thyroid. The 4 parathyroid are very small ovoid glands. They lie external to the thyroid capsule that's applied to the posteromedial surface of the thyroid. And they are again enclosed by the pretracheal fascia. So they move also with the larynx. So they are applied to the posterior medial surface of the thyroid lobe, 2 on each side. They are enclosed by pretracheal fascia, so they move with the larynx. 2 of them are superior, 1 right and left, and 2 inferior, right and left parathyroid. So I have right superior parathyroid, left superior parathyroid, right inferior parathyroid, left inferior parathyroid. Now the 2 superior, they lie 1 centimeter superior to the point of entry of superior thyroid artery to the gland. They are constant in position, and usually they are at the level of inferior border of cricoid cartilage. So 2 superior, each lie 1 centimeter superior to the point of entry of superior thyroid artery to the gland, more constant in position, and are usually at the level of inferior border of cricoid cartilage. We have 2 inferior, the right and left, lie 1 centimeter inferior to the artery entry point, superior thyroid, usually near inferior pole of the thyroid, but they are variable in position. So we have parathyroid 4 glands. They are small and are applied to the posterior surfaces of the lobes of the thyroid gland, 2 superior and 2 inferior, and they are enclosed with pretracheal fascia. They move with the larynx. The superior one lies level 1 centimeter above point of entry of superior thyroid, usually at the level of inferior border of cricoid cartilage, and the 2 inferior, they are not constant in position, lie usually inferior to the artery entry point near inferior pole of thyroid, but they are variable. The blood supply of them and nerve supply is the same from the thyroid arteries, usually the inferior one. Veins and nerves and lymphatics, they pass with those of the thyroid. So as if they are part of the thyroid gland. So in doing thyroidectomy, usually we do subtotal so that we leave the parathyroid glands intact. The parathyroid glands, they secrete parathyroid hormone, which is responsible for the regulation of level of potassium in the blood. It acts on the bones. When there is decreased level of calcium in the blood, then calcium is resolved from the bones into circulation, and vice versa. I'm done today. Now, do you have any questions? Anybody?
No, دكتور no.
انت ما عندك خمال بقية.
ما أنا دكتور.
ماكو سؤال؟
لا دكتور
ماكو
شكرا.
أحمد وأنا.
نعم دكتور.
أحمد وينك؟
نعم دكتور.
البارحة سألتني على الامتحان.
اي دكتور.
إيه.
قلت لي بالمحاضرة.
إيه هسه.
المحاضرات الداخلة ونمط الأسئلة.
هسه نحكي، أنتوا شو وقت الامتحان مالتكم؟
دكتور هو اللي يبدأ يوم 22/3.
لحد الآن ما مسوين، يعني ما معينين مو؟
لا دكتور بعد لحد هسه ما معينين.
الجدول شو
دكتور
وقت؟
نخلي أول مادة مالتك أنت يومي بكيفك.
شو وقت أنتوا بكيفكم؟ شو وقت ما تخلون؟ بس شو وقت راح
مو
يبدي؟
مشكلة دكتور، أنا أخليها ويا الطلاب.
شو وقت يبدي الامتحان؟
ها دكتور يبدي الامتحان يوم 22/3.
يوم 22/3. اي اوكي تمام. زين.
ايه.
تمتحنون نظري وعملي؟ عملي اماكم مو؟
العملي لا، هذا الأسبوع نمتحنه دكتور. الثيوري لا نمتحنه يوم 22.
يوم 22.
اي دكتور.
زين. تريدون ندخل؟ احنا بدينا بالاورال كافيتي مو؟
اي دكتور.
كل الاورال كافيتي داخل، والكونتنتس اوف ذا اورال كافيتي يعني الطنق salivary glands.
دكتور احنا بدينا بالسكالب.
السكالب شلون؟ بديتوا ايش بديتوا؟
دكتور احنا وش قدنا بالسكالب؟
بديتوا بالسكال. سكال بدينا يعني البونز الفرونت فيو واللاترال والبوستيرال انتوا العاملين ما حكيتوا تقرونها. الصف الاول نيل داون تو ما كنتوا مارين سكال بالصف الاول. انا اعرف السكال داخله زايدا يعني هاي المحاضرات مال الفارنج واللارنج والثايرويد والنك ما داخل لنهايه الاورال كافيتي. اخر شيء
يعني دكتور التونج داخل.
اي طبعا التنك داخل والسليفري جلاندز هم داخله لحد النك.
يعني النك غير داخل دكتور؟
لا النك ما داخل. تمام؟
تمام
دكتور. كلش على سيدك دكتور. الدكتور بالنسبه لنمط الاسئله شلون راح
اي
يصير؟
نمط الاسئله راح اجيب لكم 25 سؤال سنجل تشويس كويشنز.
اوكي دكتور.
والامتحان راح يكون اونلاين.
اوكي.
راح يكون عندكم 40 دقيقه تدخلون 40 دقيقه فقط عندك مجال من تدخل لين ينتهي الامتحان.
دكتور وقت قليل هيك.
ليش؟
شلون دكتور شلون؟
هي سنجل تشويس كويشنز.
يا عادي دكتور يعني حتى يزيد
دكتور
منا وقت وانترنت ضعيف وهوايه.
انت ضعيف شلون؟
دكتور النت ضعيف يتاخر حتى يحمل الاسئله والجواب ممكن يعيد يرست الرابط وعندنا اسئله هوايه يعني ملازم مو قليله.
انت تدري شنو المفروض قبل الامتحان بوقت الامتحان ب5 دقائق انت تفتح النت مالتك هاي وتحاول تفوت على الكلاس مالتك وراح يصير اناونسمنت ذاك الوقت من ينفتح انت راسا موجود تفتح وتبدي تجاوب.
عفوا دكتور ليش ما تنتهي الساعه؟
شلون؟
صحيح دكتور ما تنتهي الساعه ما زحمه وقت الامتحان طبعا. يلا دكتور بيانات يلا ما نقدر نمتحن حتى البيانات دكتور مو بس ضعيف جدا جدا. ابسط مثال المحاضره هاي انت شرحتها والله العظيم المحاضره ساعه بشاشه سود ما ظهرت عندي.
زين هاي 10 دقائق زايده صار 50 دقيقه.
دكتور سوي ساعه عادل.
ساعه وخلص.
هو هوايه ساعه شو تسوون بالساعه؟
دكتور
دكتور 10 دقائق ساعات.
دكتور
اه
مرات اصلا هو الرابط يكون نازل للطلاب بس بسبب انه النت مو زين انت ربع ساعه يطير من وقت الاجابه مالتك على ما تقدر تدخل
هيجي
تكتب بياناتك وتطلع لك السلايدات مال الامتحان.
إيه
يعني دكتور اشوف
هذا شلون هذا شلون انترنت هذا شو اسمه جاي عزه مال مو شو اسمه جاي
عندنا كل شيء ماكو دكتور نقعد الحين من جده
دكتور عندنا بال60 طالب تقريبا من المحافظات هذول المحافظات دكتور البعيده اللي يكون عندهم انترنت كلش ضعيف يعني حرفيا كلش ضعيف يعني ما يعرفون شو يسوون وخطيه بس معتمدين على اليوتيوب احتمال حتى ما يقدرون يدخلون على اللايفات وعلى الاونلاين يعني فدنهم ضعيف دكتور
ما نقدر ندخل عليها.
اوكي تمام هاي ساعه يلا شو ساعه تسوون ذا شو
تمام لا الدكتور ساعه
بارك الله
زين حيكون ساعه
كلش متشكرين منك انا ما قصرت ويانا.
شو وقت تريدون وقت الامتحان؟
دكتور وقت الامتحان العماده تبلغنا به؟
لا الساعه مالتها الساعه هم يحددون؟
اي دكتور او احنا نحدد معك بعد لان بعد 20 يوم الامتحان.
لا اوكي تمام يلا انا اخلي الاسئله ما عندي
مشكله. نتفق دكتور مو مشكله انت دكتور حضر الاسئله وسهله ان شاء الله.
تمام اوكي
ماشي
بس احنا بدنا نسكال بالنت دكتور؟
بدنا نسكال النك ما داخل.
تمام دكتور.
يعني السكال زائدا الاورال كافيتي والكونتنتس اوف اورال كافيتي اللي هي الطنج والسليفري جلاندز كلها هاي داخله لحد ما توصل للنك. تمام واضح؟ الكل سمعني؟
نعم دكتور نعم.
وراح اسوي اناونسمنت ادخلها على اسمه اسوي لكم اناونسمنت بامن على من يعلن الامتحان اقول لكم يعني شو وقت كل التفاصيل راح اكتبها بها. تمام؟
ان شاء الله دكتور.
يلا اليوم كافي. اذا ما عندكم شيء روحوا تحضروا الامتحانات.
ثانك يو دكتور.
مشكور حال دكتور.
يا هلا بيكم. تمام، اذا ما عندكم شيء you can leave now.